Hello, welcome to this afternoon's event. I'm David Adler, Interim Vice President for Policy at the Robert Wood Johnson Foundation, a leading national philanthropy dedicating to taking bold leaps to transform health in our lifetime. For more than 50 years, RWJF has been a trusted, nonpartisan resource for data and analysis that can inform policies to improve health and well-being in the United States. This summer marks the 60th anniversary of the Medicaid program being signed into law. In the past 6 decades, the program has connected millions of people to health insurance. People at all stages of life use Medicaid. Medicaid covers 40% of births in the country, more than half of nursing home residents, and 1 in 5 people nationwide. Medicaid is also a bedrock of local economies, supporting healthcare jobs and providing vital hospital funding, particularly in rural areas. RWJF is proud to support Duke University Press's Journal of Health Politics, Policy, and Law's special Medicaid at 60 issue, which provides a deep dive into the program's history and evolution over time. Today, we will explore some of the key takeaways from the special issue, including what we can learn from Medicaid's past and what that might mean for its future. I'm looking forward to our discussion today. Before we dive in, a few programming notes. We'll have plenty of time for Q&A, so feel free to share your questions in the Q&A box throughout the discussion. A recording of today's discussion will be shared with you in a follow-up email, along with resources referenced during today's discussion. Near the end of our time, we'll share a link to a brief survey in the chat. We appreciate you completing it. With that, I'm happy to introduce you to our 3 speakers. First, we have the editor of the Medicaid at 60 special issue, Eric Patashnik. Dr. Patashnik is a professor of public policy and political science at Brown University. After Eric, we'll hear from 2 contributors to the special issue, Andrea Campbell, a professor of political science at the Massachusetts Institute of Technology, and Jamila Michener, an associate professor of government at Cornell University. With that, I'm going to start by turning it over to Eric to give us a brief overview of the special edition and why it matters in this moment.
Great. Thank you so much, David. So I was the editor of this special issue of Journal of Health Politics, Policy, and Law, JHPL for short. And the issue brings together leading scholars to consider Medicaid's past, present, and future. The articles in the issue consider many important topics, including Medicaid's impact on racial disparities, its role in addressing social determinants of health, and public insurance coverage of immigrants and other groups. With the generous support of RWJF, all the articles of the issue are open access and available on the web. That's not usually the case with academic journals. And so you're all welcome to Google JHPL, and you'll be able to read all the articles directly. Today, as David mentioned, Medicaid has grown into a major institution. It covers more than 70 million people, including about 4 in 10 children, more than 4 in 10 non-elderly people with disabilities, and about 6 in 10 adults living below the poverty line. The fact that Medicaid has grown into America's largest health insurer is truly a remarkable development. Medicaid and Medicare were both established in the Social Security Act of 1965. And at the time, Medicare was regarded as the main event. Indeed, the New York Times front page article about the signing of the Medicaid of the law by Lyndon Johnson didn't even mention Medicaid. Many health reformers back in 1965 believed that Medicaid would be superseded when the U.S. inevitably enacted universal health insurance like other wealthy democracies. But what seemed inevitable in 1965 never came to pass. The U.S. failed to enact universal healthcare system. As a result, it has remained all too easy for people to fall through the cracks. Without a national healthcare system, Medicaid has emerged over the decades as a vital backstop for millions of Americans, including not only low-income people, but also middle-class families who have an aging parent or grandparent who need nursing home care, an expensive proposition which Medicare generally does not pay for. Research suggests that Medicaid is a very effective program. We have a lot of studies now that show that Medicaid coverage is associated with a wide range of positive outcomes, including improved access to health care, better self-reported health, an increase in the treatment of chronic conditions and substance use disorders, and greater financial security. For many years, it's been difficult for researchers to determine whether or not Medicaid coverage saves lives. There's so many different factors that is associated with how long a person lives. Poverty, stress, your genetic inheritance, so many different factors that it has often been difficult to sort out whether Medicaid itself makes a difference. But in the recent years, we have a growing body of scientific evidence that provides strong causal evidence that Medicaid coverage does indeed reduce mortality rates. According, for example, to a recent study by University of Chicago scholars that leverages state-level variation in the timing and adoption of Medicaid expansion under the Affordable Care Act and earlier state waivers, low-income adults who gained Medicaid coverage were 21% less likely to die during a given year than those not enrolled. And the study further calculated that these expansions under Medicaid were very cost-effective, much more so than other public health interventions. In sum, we do have a body of research that suggests that Medicaid works, that it is associated with reduced mortality, promotes economic security, and produces value for money. This is a key moment for taking stock of Medicaid's historical development and present status as this issue does. As likely everyone watching this webinar knows, Congress is currently considering major legislation on Medicaid. Legislation passed by the House of Representatives, which will soon be considered by the Senate, would impose, among other changes, strict work requirements for certain Medicaid clients. Specifically, able-bodied adults without dependent children would be required to engage in work or other community activities for 80 or more hours per month. Proponents of this measure argue that work requirements would save hundreds of billions of dollars and also give Medicaid clients dignity by ensuring that they are contributing to society. Proponents argue that they are targeting people who do not work and not targeting people who have a disability or another activity limitation. And there's some evidence from public opinion polls that the public as a whole is broadly supportive of this idea. However, work requirements are one of those policy ideas that turn out to be more complicated than it seems on the surface. First of all, most Medicaid recipients, research shows, are already working. As the economists Sherry Gleed and Dong Ding recently pointed out in a Brookings study, if work requirements work as intended, targeting only able-bodied adult Medicaid enrollees not engaged in desired activities, it won't actually save that much money. The only way probably to generate large budget savings is by disenrolling people that the proponents of this measure are arguing that they would like to protect, namely people who are already working or those who don't work because they have serious health issues or other activity limitations. The experiences of states such as Arkansas and Georgia suggest that work requirements will create significant administrative burdens for Medicaid recipients to overcome. Some people, based on prior state experience, may find themselves disenrolled simply because they get caught up in bureaucratic red tape. The Congressional Budget Office estimates that 7.8 million people could lose Medicaid coverage under the bill. Many Republicans recognize the massive impact that Medicaid has on their communities, especially on rural communities. Many rural hospitals are dependent on Medicaid dollars to remain open. And some of them are discussing Medicaid in ways that are different than it was talked about back in 2017 when Medicaid cuts were on the agenda as part of the ACA repeal attempt. Whether the growing reliance on Medicaid of many rural communities will ultimately affect the outcome of the debate over this bill in the Senate, of course, remains to be seen. And finally, one of the, I think, important things about this special issue of the Journal of Health Politics, Policy, and Law is that it not only examines Medicaid's impact as a health program, but also how Medicaid's image and design have shaped both the program's durability as well as its potential vulnerability to retrenchment. Our next speaker, Andrea Campbell, will discuss her insightful work examining what Medicaid's trajectory reveals about the conditions under which programs generate positive policy feedback at both the elite and mass levels.
Great. Well, thank you very much. And thank you very much to RWJ for organizing this webinar, and to Eric for your comments just now. So my piece looks at the historical development of Medicaid and how we can explain its trajectory. It really has become a true safety net in the United States. Many other social policies that are targeted at lower income people have been block granted or capped or waitlisted in one way or another, meaning that not everyone who is eligible can actually enroll in the program. But Medicaid has been different. Those who are eligible can enroll. And over the decades, the program has expanded to cover more and more low income Americans. What's interesting is that originally eligibility was based on both having a low income and being a member of some category, as Eric Patashnik was just describing, being a pregnant woman or a low income child, or being a disabled senior. Eligibility grew even before the ACA. Eligibility grew during the 1980s, 1990s as the level of income at which those groups could be eligible increased. And then the ACA was intended to make eligibility based solely on income and not also a category. So that would enable, for example, low-income adults without children to be eligible for the first time. That Medicaid expansion became eligible for the states with the Supreme Court's ruling on the matter. Now, 40 states plus DC have expanded Medicaid. And all along, Medicaid has been the main payer of nursing home care, home health care for the elderly and the permanently disabled, in addition to that low-income non-senior group. So why this growth? Why this durability? How can we explain this? Well, Medicaid's trajectory has a lot to do with the stakes for state governments, for providers like hospitals, nursing homes, home health care agencies, and stakes that are recognized by members of the public themselves, especially those with personal experience with Medicaid, either themselves or through friends or relatives. And there's three ways to think about these stakes. And this framework that I use in my paper is called policy feedbacks, which is to say that the nature of existing policies has effects on the political landscape. It has effects on members of the public, on interest groups, political leaders, how they think about a program, the kinds of resources they bring to bear. And in other words, existing policies affect the political terrain, which affects subsequent policymaking. So in that framework, if we think about Medicaid, there's three things. One is the program's design, specifically the fact that it is a hybrid state-federal program with both states and the federal government contributing to its financing. For every dollar that states spend on Medicaid, they get at least one federal dollar, more if they're a lower income state. This federal match has encouraged what's been called catalytic federalism, with states and the federal government experimenting with enrollment, coverage, and over the years expanding eligibility. A second kind of feedback is the robust defense that Medicaid has experienced from stakeholder groups, including state governors, hospitals, nursing homes, and so on. Think about their stakes in the program. They need their low-income populations to be insured. Otherwise, care that is given mandatorily in the case of hospitals will be free care if those folks are not enrolled in Medicaid. Medicaid, compared to Medicare and private insurance, doesn't reimburse very generously, but low reimbursement is very preferable to no reimbursement, hence the support of hospitals and other stakeholders in the program. And Medicaid is crucially important for rural hospitals because of the high rate of eligibility in rural areas. And then the third factor is the inclusion of constituencies in Medicaid beyond the low-income core. These include middle-class constituencies for whom other public or private insurance company coverage is difficult or impossible to acquire. For example, Medicaid covers intellectually disabled children. It is the default long-term care program for nearly all Americans, except for people who are so affluent they can cover the huge cost of nursing home care and home health care themselves. For the vast majority of Americans, it's Medicaid, right? So even before the ACA, eligibility had been expanded to many members of the public, the working poor, these other kinds of middle class constituencies who've become robust defenders of the program as well. If you think about North Carolina, that was the most recent state to expand Medicaid under the ACA, the 40th state to do so. And what was interesting about the argument that was made by proponents in the state legislature trying to get fellow legislators to agree to the expansion, the argument was very much about the protection for rural hospitals, rural residents, farmers, veterans, families that have been affected by opioid or other substance abuse disorders, effects on local economies, not so much about the low income constituencies that have historically been associated with the program. The other thing about Medicaid is the support has been bipartisan. We see that in governors of both parties over the decades, recognizing the importance of those federal matching dollars for the financial viability of their hospitals. Hospitals are major employers in many areas of the country. Hospital closures can devastate a local economy, heighten the risks for patients who have to drive long distances for care. And so Medicaid's role in ensuring the financial viability of hospitals, especially, but not only in rural areas, is important for patients well beyond Medicaid enrollees themselves. And you also see bipartisan support in recent years with Medicaid expansions in the ACA era, some expansions approved by Republican governors and Republican-led state legislatures, also by voters, even in traditionally red states that have voted for expansion through ballot initiatives. All that said, Medicaid is in many ways robust, far more politically robust than many means-tested programs, but also politically fragile. It is recognized as a vital program for states, for providers, for consumers alike, but it remains vulnerable because it's still a means-tested program. During periods of budget cuts, means-tested programs have historically been easier to cut than universal programs like Social Security and Medicare. It is the case that these kinds of feedback effects that I've talked about that have contributed to the protective shell around Medicaid have operated more through the kind of political elite and stakeholder channels than through the mass public channels. Because many of the core members of Medicaid's constituencies, those low-income folks, do participate in politics at lower rates than, say, the recipients of universal programs like Social Security and Medicare that can count on high voter turnout among senior citizens for political protection. So Medicaid is distinct from many social welfare programs, but also its welfare roots always lurk under the surface and can come to the fore at moments when it's in the political crosshairs. So there's many other things to talk about, but I will stop there and turn the reins over to the next speaker. Thank you.
Thank you. And with that, we are going to turn things over to Dr. Michener.
All right. Hi, everyone. I have some slides that are, thank you so much, David. And it was great to have the two panelists, Andrea and Eric, go before me because I think they laid a great groundwork. And so I'm going to try to jump right in and take us, to the end of our period of comments for the next few minutes before we can jump into some more conversational mode. But hello, everyone. What I want to focus on, I think, is picking up right where Andrea just left off, right? Which is this kind of history and status of Medicaid as we know it now that we've been hearing about over the last few minutes have led us to a point where obviously, Medicaid is in the news when Andrea says like, well, Medicaid is different than your traditional kind of quote unquote welfare program. And we could see that in levels of public support, the way that people view the program, the way it's expanded and grown over time, and lots of other kind of metrics. We know that Medicaid is different. And at the same time, Medicaid is vulnerable. And so one question, especially given some of the things that Eric Patashnik said at the beginning around how many people Medicaid is really vital, is sort of how do we think about the future? How do we think about where Medicaid is going, right? And to the extent that there are folks who believe that Medicaid is important and that there's evidence, lots of evidence, I think, to suggest that Medicaid and to indicate that Medicaid is vital for sustaining the health and well-being, particularly of low-income families in the US. How do we think about a politically vulnerable program like Medicaid being able to sustain into the future? Next slide. So that's what I'll focus on here. And, I'm a political scientist, so I think about the political dynamics of Medicaid. And when we talk about Medicaid politics, whether it's myself or Andrea Campbell or anyone on this panel today, I'm not thinking about politics in the sense of like horse race politics, like what we're watching in the news, or in the sense of, what Democrats versus Republicans or what have you. Of course, the partisan dimensions to politics are part of politics and elections are a part of politics. But really, as political scientists, we think about this on a sort of different register that's not about like, what are your political perspectives, but are instead about who is able to influence and act to affect policy in a democracy, under what circumstances, in what ways, and how does that help us to understand who gets a voice, and how does that help us to understand who gets what, when, and how, right? Which is essentially what we think of as politics. It's about who gets what and what that means in the context of a democracy. So maybe abstracting away from the kind of nitty gritty horse race politics that we might be seeing on the news every day and thinking more broadly about who has influence in democracy, there's lots of research on some of the different groups of people and kinds of interests that tend to hold sway when it comes to shaping Medicaid politics and policy. And so we know, for example, that governors matter. Partisanship does matter. For example, on the state level, what party controls a legislature or the governorship, these things are important. Ideology matters. What people think, public opinion, it doesn't dictate everything, but it holds sway. But one of the things that I'll point out that's consistent with what Andrea said at the end of her comments is that for the most part, the tens of millions of people that rely on Medicaid themselves have not traditionally been a major part of this landscape of who's getting to influence the future of Medicaid, the trajectory of Medicaid, where Medicaid is going. The people who are most affected by the answer to the question of where Medicaid is going, traditionally, per what we've seen in the kind of landscape of research on this, have not had a lot of voice and influence over that trajectory. Next slide, please. And so one of the things that I do, or the main thing I do in this paper that's linked in the webinar chat, is really think about what we've seen in a lot of political science. And I think what is reflective of what's happening in the world, as Andrea indicated, is a kind of top-down approach to Medicaid, right? So the very political, economic, other elites, organized elites get to say, here's what our interests are as a hospital group or as a business owner who's going to be affected by this decision. And that's important. In a democracy, all of those folks get a voice and should. But what about the sort of bottom up? What about the very many tens of millions of Americans who will be directly affected by any changes that happen to Medicaid? And really, what the research that I do in the paper that's linked is I think about, well, where does that fit in? Where do they fit in, and how does that matter as we think about the future and trajectory of Medicaid? So a bottom up kind of perspective. Next slide, please. And one of the things that that emerges as I interview many and talk to many advocates and organizers and people involved in the Medicaid policy space is that they say that, it's really important that we have the voices of the people who are most affected. That actually matters, and it might change what we do. It might change the trajectory of Medicaid policy, right? And so that's something that we've been thinking more about, that many people who may traditionally take a more top-down approach and have been a part of kind of top-down advocacy and so on and so forth, when it comes to thinking about what happens with Medicaid, there's more and more recognition that actually the communities of people that are most impacted, who tend to traditionally be left out of decision making, maybe because they don't participate in politics as much, maybe because there aren't as many pathways being open to facilitate their participation for a variety of reasons. More health policy advocates in the Medicaid space, when I interviewed them for this research, said, actually, this is probably a space that's important for us to move into, to think about as we think about the future of Medicaid and where it's going. How do we bring along the people who are most affected and make sure they have a say in that process? Next slide. And of course, right now, what many people in the advocacy and health policy space report when asked about, well, what shapes what Medicaid policy looks like? Like, who's making these decisions? We know most immediately, of course, our elected officials on the state level and on the national level are making these decisions, but they're being influenced and engaged by a number of different stakeholders. And so who are the primary and crucial stakeholders? And most advocates say, actually, like, not people on the ground, not people in communities most affected, for a number of different reasons. One, because that's really hard. It's hard to get to those folks, to engage them in these processes. And one, because people do what they do, right? If I do advocacy, and my advocacy means as a professional advocate, I'm trying to reach people in legislatures, state legislatures, or Congress, then that's what I do, right? And we really don't go outside of that. Next slide, please. So most people agree, probably good to have the voices of the people most affected involved, but we don't tend to do that. And when you talk to the people most affected, so this is based on hundreds of interviews that I did with people who are Medicaid beneficiaries, they actually confirm we're not really involved, right? And when we ask people, do you think you have any say over what happens with Medicaid? Over and over again, they say things like, no, we're not included in those decisions. No, we don't have any influence. No, we don't think people who know what it feels like to use these programs are actually involved in the process of shaping them. And so we might think of this from the standpoint of democracy, not any kind of partisan perspective per se, because Medicaid beneficiaries actually span the partisan gamut, right? This isn't like we need more Democrats involved or we need more Republicans involved. This is, well, what does it mean to not have involved in the process the people who are most affected by the process? Next slide, please. And one of the things that's one way to look at this as we think about the trajectory of Medicaid is as an opportunity, because people say that they think they should be involved. So some folks will say, well, those folks are too busy. Medicaid is too complicated. It's not a realistic expectation to have the people being affected involved in the process. But when you talk to those folks, they don't say it's too complex, I'm too busy, I just can't wrap my mind around this. They say, we don't have a say, but I wish we did, right? They say, I don't think anybody listens, but it would be ideal, right? It would be perfect if they actually did talk to us. And they say that, you know, the people using the benefits, what they think, their understandings of these policies and programs, that matters too, right? And so they should be heard. Next slide. And of course, when we think about, well, are people actually willing to do something? Like, if we try to get more people involved who are actually affected by Medicaid and understand their perspectives as we make these decisions, is that really a feasible or realistic expectation or possibility? In a really recent survey in just April of 2025, we actually asked people their opinions, both about some of the things that were on the horizon with Medicaid and about, you know, whether they would be willing to act, right? We didn't push them in any direction or the other. And we didn't ask them whether they were going to be acting in terms of partisanship. We just asked them about their perspectives on Medicaid and their willingness to act. Many people, this is from research, this is from a survey that we did. Many people said that they opposed, who said this is among people who said they opposed Medicaid cuts, and that's Democrats and Republicans. Many of them say that they're going to be looking for information about Medicaid. They're searching for ways to get involved to protect Medicaid. About 56%, 45% said they would work to raise that awareness themselves. 40% said they would actively contact elected officials. About a quarter said that they would be trying to identify and look for groups to work with to be a part of the process of trying to shape the trajectory of Medicaid policy. And about a little over 1 in 5 said that they would even volunteer their time, right, for a campaign or a candidate. Again, this isn't in a specific valence in terms of partisanship. And this is what people told us when we asked on the survey. And so we surveyed people from across the kind of demographic and partisan and ideological spectrum. So the broad point here is that thus far, when we think about the history and trajectory of Medicaid, the people most impacted, the people who are receiving the benefits themselves, haven't been a big part of the policy landscape. The folks who are a part of the landscape, the advocates, the policy organizers, they say they recognize that really as a problem, right? And as something that we might want to think about doing differently. They might want to think about doing differently going forward. And then when you talk to ordinary people themselves, they say that they do want to have a voice and that they are willing to take action. So something to think about when we think about this larger landscape and who gets to have a voice and who doesn't as Medicaid continues on its trajectory. I will stop there.
Thank you. And as we pull all the panelists back on stage, so to speak, I just want to thank all of you for that really informative overview and sort of analysis of the sort of politics and the factors that have shaped Medicaid. I've got a few questions coming in that I want to start to ask, and I will maybe start with almost in the order that we started. So Eric, this was a question about, you mentioned work requirements, and there's obviously a wide sort of literature on the effects of work requirements and how it affects people's enrollment and often results in disenrollment. Can you talk a little bit about, even for people who maybe are meeting the requirement, why they might end up losing coverage and some of the administrative hurdles that are involved in that?
Yes, so thank you for that. It's an important question. So I think researchers have understood this under the framework of what is called administrative burdens. And really groundbreaking research on this topic has been done by Pamela Hurd, who has an article in the special issue on administrative burdens and Medicaid long-term care, not on work requirements, but a very analogous kind of process. And she has done work in this issue with Rebecca Johnson of Georgetown University. But Pamela Hurd has done really groundbreaking research with Donald Moynihan. The two of them together are the leading scholars in this area. They're both now at the University of Michigan. Their book, Administrative Burden, is really a must-read for anyone working in this space, highly readable, but they've published a lot of issue briefs and other things you can find on the web as well. And what they're really talking about is just because a client is eligible for a particular government program, whether it's Medicaid or any other, doesn't mean that they can automatically access the program, even if they have a legal right to do so. There are a lot of steps that have to be overcome. The client has to learn about their eligibility for the program. They have to fill out paperwork. They may have to do that repeatedly to demonstrate that they continue to remain eligible. At every step along the way, something could go wrong. You might miss a notice. You might accidentally fill out a form incorrectly. Maybe the form was sent to you with not the correct email address, or maybe your income it fluctuates. And so your eligibility, you're eligible 1 month, but you're not the other month. All of those kinds of things can cause administrative burdens to come into play. And Moynihan and Hurd really talk about 3 kinds of administrative burdens, if I'm going to remember them right: learning costs and psychological and compliance. And I think their schema is extremely helpful for anyone who's working in the space to try to evaluate the policies you're implementing. How easy is it for your eligible population to learn? How hard or difficult is it for them to comply with demonstrating that they're eligible? Is there psychological stress that's involved with the intake process? And what we've seen is that although these sound like trivial or routine matters, they really aren't. Unfortunately, the way government works in the real world is just all too easy, even for people that are absolutely legally eligible under the law to obtain a benefit, for these administrative burdens to trip them up. And the experience of states like Arkansas and Georgia that have implemented strict work requirements broadly similar to the kind that's under consideration now suggests that these administrative burdens have a massive impact even on people that are eligible. And so some of the people that are going to be disenrolled, if the federal experience, if this goes through, and if that federal experience is similar to the state experience, though some of those people will in fact be people who should not be disenrolled because they are eligible. And it's just that they were unable to keep up with the necessary paperwork. And the proposed law not only imposes new work requirements, but it's going to require people to reaffirm and redemonstrate their eligibility more often, more frequently. So if you miss an email, you miss a letter, maybe you've moved, people's lives can be complicated. You are absolutely legally eligible, but you fail to receive that notice on time, perhaps through no fault of your own, you could easily lose eligibility. And what the research shows is that these administrative burdens are opaque, they're hard for people to understand, they increase inequality, they disproportionately burden marginalized groups, and they really are at the center, I think, of the law. And so in the special issue, there is one of the articles that does look at this head on, and I would encourage people to take a look at that.
Thank you. Yeah, and I think that is that's really helpful also to put this conversation in the context of administrative burden, which in and of itself is a huge topic, and as you said, I think cuts across a number of areas. The next question I think I'll direct at Jamila, which is, given your research, how would you advise people who are working in the health policy space to reach people who are more impacted by Medicaid? And I think, if there are examples of where you've seen this done well, I think it would be great to share some of those.
Yeah, thank you for that question. And, it's an exciting question to me because it's exactly the kind of thing that I have seen happening more and more, and I think can be quite fruitful depending on what your goals are. But one of the things that comes up in the paper and that comes out through the interviews that I did in connection with the paper is people in the sort of health policy space recognizing like, okay, to get any further, we're really probably going to have to bring in the many, many people who are most affected by this, and realizing that those that's not necessarily how those aren't the networks and the capacities they've been building. So how do they do this? And one of the things that comes up a lot is looking for who has been building those networks and capacities, but maybe doesn't have the policy expertise you do or the resources that you do, and looking for opportunities to build bridges and connect there. And sometimes that means really reaching out to and working in coalition with more grassroots community-based organizations. Sometimes it means building those in the longer term. It might mean building some of those capacities in-house for yourself. I will say that right now, not partially funded by the Robert Wood Johnson Foundation, actually, I'm part of a project. And what we're doing is like health policy researchers are working with a national advocacy organization that has connections to community-based organizations all over the country. And the researchers are facilitating in-depth focus groups and research that allows us to really bring in and connect and talk to the people who are experiencing Medicaid policy in a really firsthand way. And we're connecting that both to the kind of like planning around advocacy that's happening, but also to the community-based organizations and sort of facilitating connections across those spaces in this ecosystem, I think is hard. But it's doable and it's happening. And so excited for other folks to be looking for opportunities for that too. And appreciate the Robert Wood Johnson Foundation for helping to facilitate sometimes those difficult to build bridges.
Well, that's great to hear. It's nice to hear that that work is happening and that we're able to support that. I have actually one follow-up question on that before I shift to a question that I think I'm going to send to Andrea, which is in reading your paper, Jamila, there was one of the questions that came up, and this is related to actually what you just mentioned, and feel free to talk about what could be better about work that the Robert Wood Johnson Foundation is doing or different. I was curious if you had a point of view on kind of the coalition that brings together those different pieces or organizations trying to build those different capacities themselves. And I don't know if you see trends or ways that plays out or have a point of view on sort of which model is better, but I was really curious about that.
Yeah, I love this question. And I don't necessarily have a point of view on which model is better, but from the research, I can tell you the challenges embedded in some of the models. So the challenge of trying to do it all in-house, like outside of the coalitional model, is that often it creates tension. So if you are an advocacy organization, you have a more grass tops approach, like you're really trying to engage state legislators, and you've built your relationships with state legislators or national legislators. And those relationships are a really important part of how you try to engage change, right? From an advocacy perspective. Now you start to build out some grassroots capacity, and you have affected community members that are now directly in your organization. Sometimes the way that they will engage the elites that you've been building those grass tops relationships with is going to be collaborative and mutualistic, and that's awesome. And sometimes, because this is politics, right, on across the spectrum, those are going to be conflict-oriented relationships. You're going to be trying to put pressure, put the squeeze on those elected officials from the grassroots perspective. And now those are the same officials you maybe have been building relationships with for years or decades. And so that's two very different masters to be orienting oneself towards, just on a practical level. Many advocacy, health policy folks in the advocacy space say it's really hard to hold those things at the same time. At the same time, there are folks who do that. And the challenge on that end, I will say, is that it's resource and work intensive, right? It's really difficult to have strong capacity in two very different kinds of areas in your organization. And so that kind of thing is hard to do without support. And it also means you have very different kinds of people that have to be able to interface with each other. And, professional advocates tend to be folks that maybe look like a lot of us that are on this panel today, right? Highly educated, have super technical and highly informed perspectives on policy and how to approach it and change it based on their knowledge and research and so forth. And when you're dealing with folks who are coming from a very different experiential perspective and sometimes very different life backgrounds, that's not easy to reconcile. It takes real work and it can be challenging from an organizational perspective. So there are challenges on either front, is what I would say.
Okay, no, that's really helpful. And so I appreciate that, and I appreciate that kind of perspective on the different ways it could play on the different roles of organizations. So we do have a lot of questions, so I'm going to try and keep them going. So Andrea, I actually think this might be a good one for you to speak about, given the history of policy feedbacks and frankly some of the challenges that have been levied against Medicaid. So one of the things we hear a lot is about waste, fraud, and abuse in the program. And I'm interested, based on your work, if this has been a frequent criticism of the program, and if so, has it been more sort of targeted on kind of the individual recipients or kind of the providers or other people who you've described as stakeholders and actors in the program?
Yeah, well, that's a very interesting question. There's the rhetorical aspect of the waste, fraud, and abuse allegation, and then there's the reality of it. The rhetorical targets are oftentimes the individual recipients, right? That people are enrolling in programs like Medicaid and other means-tested programs who maybe shouldn't be, right? This is sort of adjacent to, they don't, we have a lot of sort of deservingness discourse in the United States about who deserves help, who has earned help or hasn't earned help, and so on. adjacent to that is who's actually abusing the system, right? And so a lot of the rhetoric focuses on individuals. To the degree to which there is waste, fraud, and abuse, it's actually sometimes more carried out by institutional actors that actually have the ability to do that. That said, there's far less waste, fraud, and abuse than I think some folks imagine in these programs. I mean, in many ways, Medicaid is an extraordinarily low-cost, efficient way to deliver health insurance to millions and millions of people. The administrative costs are low. Most states have the majority of their Medicaid recipients in managed care and are working under a capitated budget to provide those healthcare services for those recipients. And so, administrative cost, it's quite efficient, right? Compared to alternatives, right? And so it's just that I think rhetorically it's a very, it can be a very politically charged and convenient allegation if you're thinking about trying to cut the program. Yeah, so that's sort of another perennial in the politics of these kinds of programs for sure.
Thanks. And, maybe following up on that, and then we'll just see if others have something to add. One of the things that all three of you talked about is that this is a federal-state partnership, which makes it very different from Medicare and Social Security that are administered through the federal government. One of the things is that allows for major state variation, either through their plan design or through waivers. I'm interested if there are ways where that has created, if you see sort of benefits or drawbacks to the program in terms of having that much state-to-state variation. And I don't know, Andrea, since you were just answering, I'll start with you, but then if others want to chime in, we'll see if there's any perspective on that.
Oh, sure. Well, just to give a sense of what the kinds of things that do vary, like literally your benefits can vary. How many prescription drugs are covered for you versus in a different state? Do you have dental or not if you're an adult? Can you get eyeglasses or not if you're an adult? So that gives you a sense of the kinds of benefits that vary. Is there an asset test for those who are the original eligibility categories or not? Is that asset limit $2,000? Is it $10,000? Or are you in one of the states where there's no asset test? There's an income limit, but no asset test. So I'll just start there. And there's obviously pros and cons of that, right? And Jamila is the nation's expert on federalism and state she should take it from here.
I won't say much because I think Eric has something to say too, but I'll say two things. One is like just to loop us to the other parts of the conversation we've been having where we've been talking about these policy feedback loops where the way that Medicaid policy is designed or the way it's implemented or just what it is at any given point in time has implications for not only what it is in the future, what it becomes, but what the kind of politics are. And I'll just say this piece of Medicaid, the fact that it's different in different places, has real implications for its politics in the sense that it has implications for how people understand the program and how they respond to it politically. And so in part of my work, what I show is that feature of Medicaid actually leads to different feedback processes in different places. Not for reasons that are systematic or substantive, but quite arbitrary. You cross the state line and now Medicaid beneficiaries may be more likely to participate in the political process because they're experiencing the program in really positive and respectful ways. And across the state line, they may be experiencing it in really alienating and challenging ways. And so they're less likely to engage in the political process. So all the dynamics that we've been talking about this whole time are not only playing out on a national scale, but vary on the state level. And so this piece is really important for both the nuts and bolts, what people are getting, and for the larger, like, what are the stakes for our democracy?
And I would just add, these issues really are the tensions that run through Medicaid's political development from its origins. And there's a terrific article in the special issue by Colleen Grogan of the University of Chicago that is about how a fragmented and unequal program has expanded over time. And really the theme of her of her piece is about these key features of Medicaid: federalism, intergovernmental financing. On the one hand, the way in which they've created incentives for growth. On the other hand, they've also led and reinforced spatial and geographic inequality. They've made it harder for people to understand how Medicaid works. After all, in many states, Medicaid isn't even called Medicaid, right? It has almost 50 different names. And so that's another thing, tying on to Andrea's point about sort of mass level feedback effects. Some of the people that are on Medicaid in some of these states, quite deliberately, because of the role of elites, may not even fully understand that they're on Medicaid. They may think they're on another program. These governors and state legislatures, as they've expanded Medicaid, often in response to pressure from hospitals and other elite groups, have sometimes had political reasons to label it differently than in other states. And all of this has meant that the program simultaneously, because of the generous federal intergovernmental financing, has had the potential for growth, but it has meant that what you get from Medicaid depends tremendously on where you live. And it has been harder for citizens to understand their relationship to this program than, for example, to programs like Social Security and Medicare.
Can I make a 3-second comment, which is
Please.
just a funny reflection, or I think funny reflection on something Eric just said. Arizona's Medicaid program is called the Arizona Healthcare Cost Containment System, right? I mean, and then California's Medi-Cal. So like the whole spectrum.
Yeah. And I think, no, that's a great point. The one that always sticks out fondly is Badger Care.
Badger Care is a good one, yeah.
Seems cute and welcoming, not cost containment.
Exactly. This is a separate thing, but probably we could get together and do the sort of like Jeopardy of like, can you match the Medicaid name to the state? But that's probably a different webinar for people who want to get into the different way. I do want to ask, though, just speaking about this variation, if there are work requirements that are a requirement coming out of whatever Congress does, my guess is there will be very different ways of states implementing those. And so I am interested if any of the three of you have thoughts about ways that, some of the risks we talked about people being kicked off the program for administrative burdens and different things. Are there ways to mitigate that? And are there ways that both state government advocates, scholars can also be laying the groundwork to use as a way to think about future policy innovations in the program?
So I would point to people, to the Better Government Lab, which is co-directed by Don Moynihan of the University of Michigan, who I mentioned earlier. They've done, I think, a lot of work on implementation and ways of managing administrative burdens. I don't have a specific study to point to, but that's a group of scholars and researchers that are working in this space empirically with partners, state governments. But I think you're quite right, David. Even though there will be if this law is ultimately passed, a fairly severe federal framework, nonetheless, the way in which it's implemented at the state level will make a big difference. And I'm sure there will be some dimensions of play administratively, and states will be experimenting with different ways of trying to manage that law in an effective way.
Yeah, I would just add, so I've been in some conversations already with folks in state agencies who are thinking in advance about this. And also it's already showing that there's lots of play here. There will be it depends on the contours of what's determined at the federal level, but generally with Medicaid, and I can't imagine it will be different with a work reporting requirement, that there's going to be play. And I haven't heard this directly myself, but I've heard from some of my partners that I have been talking with, that some states are like, if we design a really strict work reporting requirement, that's going to be a way for us to even cut costs, right? Because our states spend a lot of money on their work reporting or on the Medicaid program. So if we make it so that you can only report at certain times in certain places, mostly through the internet, we don't really have much capacity for doing it over the phone. We don't really have much capacity for accepting walk-ins in our agencies, right? Just without building out the capacity that it takes a lot of capacity for these agencies on the ground to be able to implement work reporting requirements. And some states will invest in that capacity, invest in outreach, invest in informing people about whether or not they're eligible, and other states will not. And so that will make a really big difference. So the work reporting requirement will not be equally, the effects of it will not be equally distributed. And if history, like if the past with other programs like where we have seen these kinds of requirements like SNAP and TANF are any indication, the most low income people will likely bear the brunt of the burden of the administrative burden the harshest, and that brunt will also be distributed differently across racial groups, right? And so some states want to pay attention to this to try to avoid it. And other states will use what we know to kind of lean into this to try to save themselves resources. It'll be a very different, a very varied map in terms of how it plays out.
Thanks. And maybe just if I'm going to try and squeeze in one last question. So it's like the lightning round, which I feel bad because it's about children and how they have been affected by changes to Medicaid. And so I just wonder if someone could speak to how some of the things we should be watching out for in pediatrics, and maybe some of the ways that Medicaid is benefiting children right now. I know it's a big question.
I will just say one quick thing and then I'll be quiet because I've been talking a lot, which is I'm really struck, and I've been emphasizing this for folks, by the research that shows that parents' Medicaid enrollment has really significant implications for not only whether children are enrolled in Medicaid, but how robustly they use the Medicaid program. So in other words, if you have parents that are enrolled in Medicaid, their children are more likely, for example, to go for their annual WellCare visits versus when the parents aren't enrolled, right? And so one of the things that I always emphasize for people is that families are embedded and connected. And so the idea that we can hive off parts of them, like we want to keep covering and helping the children, but we're going to take benefits away from the parents, we certainly can do that, right? That's within the ambit of policymakers to decide to do. But the effects are spill over. And if we see lots of parents losing coverage, we're going to see the effects spill over to children, is what the evidence suggests. And that might not necessarily mean that they fall out of being covered, but it will likely mean fewer primary care visits.
Mm-hmm.
And that has effects throughout the whole system in terms of costs, et cetera.
And I'll say one very quick thing about people at the other end of the age spectrum, because I study senior citizens a lot. Administrative burden and senior citizens is a huge issue. And one of the things that the proposed law does is delay some reductions in administrative burden that were going to go into effect to make it easier for senior citizens who are duly eligible for Medicare and Medicaid to get into medical savings programs, to get into the Part D, the prescription drug low-income subsidy program. There was some new regulations to make that coordination easier, some auto-enrollment programs that would now be delayed for 10 years. They would have gone into effect next year and would be delayed until 2035. So there's concerns here at all ends of all parts of the age spectrum in terms of what coming changes might mean.
That's really that was a really important point. Thank you. And I'm actually sorry to have to end this conversation because I feel like we could keep going, but I really have enjoyed this conversation. I hope others have as well. I want to just extend a huge thank you to Doctors Patashnik, Campbell, and Michener for sharing your insights and expertise. And I want to thank everyone who joined our conversation this afternoon. We appreciate your time and interest. We've put a link in the chat for a brief anonymous survey. It's very helpful for us in terms of planning future events. And we will also provide a recording of this webinar and a link to the survey. Thank you so much for joining us, and enjoy the rest of your day.